welcome to my podcast. It's great having you here. Wanted to know and learn about your practice and what led you to the world of surgical oncology, specifically in the field that you are.
That's a great question. I think early on, we come from the same kind of backgrounds. Of course, we have hardworking immigrant parents that pushed us and were themselves very decorated with degrees. And when I was a teenager, I had a benign salivary gland tumor. I was in 8th grade and I felt a lump kind of thing. And I remember that experience very well because I venerated my parents as being the smartest people that I knew. But that was a time that I saw them completely vulnerable. And I just thought, wow, there's this other person, this surgeon, that knows more about me and my body than my parents or me. And I thought that whole process was interesting, and watching my parents be very frightened about it and just having the surgeon belay their fears and explain it with diagrams. I thought looking at my MRI, looking at my brain and I had a head and neck MRI was really cool. I brought it into my biology class, and that was my mark. Going through surgery, that was all fine. As I got older, in undergrad, I was a student at Harvard, and I was lucky enough that kind of through they had a career office and they have a long list of people that you could contact if you wanted to shadow them. And I tried to shadow a surgeon and ended up not working with him directly, but one of his colleagues. But basically, I worked with Myron Schwartz, who's a liver transplant surgeon in New York City, very well respected man internationally. And that was the summer between freshman and sophomore year. And that was like a life-changing summer because I just followed the surgical team around in transplants. And as you can imagine, liver transplant especially is just a very intense thing to watch, to see the patients and the approach to care. For me, that was just a summer where I was like, oh, I have to do this. This has to be a part of my life. And then, of course, I went on finishing undergrad and ended up back at Mount Sinai, which is actually a few blocks away from where I went to high school. That's how I ended up in Sinai. I volunteered there when I was an 8th grader. And then I did general surgery, which is broad training in surgical care. I had a little diversion where I was interested in pediatric surgery for a couple of years, but then the neonatal ICU I thought was very scary, and I didn't like that. I wanted to deal with adults. Went back to the world of liver and big abdominal surgery, and then got exposed to cancer surgery, which has some overlap with transplant. A little bit different approach. I liked the holistic work of looking at things from a medical side, not just a technical decision-making about whether or not I can do an operation, but also whether I should. And so that's how I done surgical oncology, GI surgical oncology, which broadly includes, at least in my practice, liver tumors, pancreatic cancer, stomach cancer, and then I'd say the miscellaneous other kinds of rare tumors, neuroendocrine tumors, appendiceal cancer, lots of kind of unnamed things or sarcomas of the abdomen, which are rare, but also it's hard to find a person that only does one of those really rare tumors. So many of us bring together a bunch of rare things and then become the expert on that. But yeah, my practice is completely clinical. I know one of our topics we had discussed was research, which I've done a lot in the past. Currently, I'm a very high volume kind of clinical surgeon. I do about 50% pancreas, liver, and then 50% kind of other abdominal surgical oncology. And yeah, I love what I do. It's hard. I have an old school job. We're not shift workers. We are here until the work is done. We're on call for our patients. We're there if there's a problem for the most part, unless we're rare times that we take vacation. So it's a lot of connection to the patients, even though we're surgeons, which people don't necessarily think of as being a job where you have a long-term relationship, but we do, because we'll see them. If I do a Whipple for pancreas cancer, I'll see them forever.
And where do you practice right now?
Yeah, so I practice in Atlanta in a system called Northside Hospital Cancer Institute, or Northside Hospital System. It's a 5-hospital, very large community practice. So very busy. It's an interesting environment, not academic in that we don't have a lot of trainees, but I would say practice with the academic mindset. We have tumor boards, multidisciplinary conference every week and all the different specialties. So it's not just one GI conference or one cancer conference. It's liver and pancreas conference and colorectal conference and melanoma sarcoma conference. And every subset has its own weekly hour-long meeting with 20 plus doctors looking at what's the best pathway forward for this patient. And we do have some clinical trials that we can encourage patients to join in, but I attend all the academic conferences that are related to my field annually. So it's a great environment. I think one of the things that's different, I probably have we have a lot of extended providers, advanced care practice providers like PAs and NPs rather than residents and fellows and students. Definitely miss that teaching someone who's going to be a surgeon is a different experience, and I miss that. There's a lot of teaching that goes on with APPs, advanced practice providers. And I think that in a community practice, we reduce the layers between the patient and the doctor. Somebody's coming to see me, they will see my PA briefly, but then I sit down with them and I'm doing most of the discussion. Rather than in an academic center, sometimes it's layers of you're seeing the student, you're seeing the resident. And similarly, if there's any issues in the perioperative period, I'm finding out about things related to patient care much sooner. And there's not layers of communication. Another thing is, it's very easy for me to pick up the phone and call the other doctors. So if I have a patient with chest pain and I'm not relaying it to someone, I'm not asking someone else to make the phone call to another resident to get the attending. I pick up the phone and I call the chief of cardio oncology and say, hey, I have this issue. I have this patient. What do you want to do? So that's really nice. I think in some ways that is a model of care that is a little old school, but I think we miss that in a lot of environments today.
Yeah, I think that's changing because of how medicine has evolved. As an internist, I have patients and they're all very eager to stay healthy. So obviously we go over preventative care and all the things, the screenings, everything that they can do. But the one question that comes up, pancreatic cancer, how do I screen for it? Or I have ovarian cancer. What are my chances of having pancreatic cancer? I'm not necessarily asking you the answers for both, but the screenings for pancreatic cancer, unlike colorectal cancer, unlike breast cancer, there's nothing that I can really advise patients. So what approach do you take or advise patients when it comes to that?
It's a great question. I think people are very scared of pancreas cancer just from what they hear in the news and the media, and probably from their friends and family too. Yes, there are no national guidelines advocating for the general public to undergo screening for pancreas cancer. So I think then it goes to, for the general public, which is no genetic mutation, no history, what are the risk factors? And we can talk about that. Obviously, I think any kind of, and this is not just pancreas, but any kind of GI symptom that to me is not getting better. So abdominal pain, nausea, vomiting, unexplained weight loss, for pancreas, back pain, things that have no explanation, I think need further workup. And this is where my best friend from college, my Harvard roommate from freshman year, Elizabeth put in, she's the chief of family medicine, Salem Hospital in Massachusetts. And I think it's such a hard job that you guys have, right? We think that, oh, cancer surgery, that's a hard job. But when I talk to her, I'm like, oh my God, you have 100 people a week with abdominal pain. It's easy for me to sit in my office and say, everybody should get a CAT scan. But she can't do that, right? You can't do that. And that's the struggle, is what's just the indigestion and what's something that's more serious. I would be interested in your commentary, but from my end, I think something that's refractory, that's new and unusual and not getting better with the general first line medical treatment. I think, in my opinion, endoscopy, colonoscopy, and an axial imaging, which is a CAT scan or an MRI with contrast. That to me is, if you've done all those things, and they're done with good quality, then the chance of you having something, I think, is low. I see a ton of patients that have gone through a 6 to 12 months to sometimes longer process where they've had first early symptoms, then going back and maybe not getting better, where maybe they got some blood work, then maybe they got an EGD, but they didn't get a colonoscopy. Maybe they got an ultrasound, but they didn't get a CAT scan, or they got a CAT scan, but it wasn't with contrast. So I see that a lot where snippets are done on the whole workup, but the whole workup is not done until the very late stage. And this is where we're going to get into advocacy, right? Where, of course, We have a whole range of patients. We have patients that are very well informed, that are on ChatGPT, that read everything, know everything, and are right on top of their symptoms, maybe a little bit too much sometimes, but they're more likely to go back to the doctor, go seek, I want to see a specialist, get the referral, get extra stuff done. And I know that there's a downside to also over screening, and that may be outside the scope of today. But we also have the other side where we have patients that, first of all, may not have insurance, or if they have insurance, it's still difficult for them to make time to get to see a doctor. Many times, in some ways, going to the first doctor, whether it's the emergency room or their PCP, some people, I think, feel like, I went to the primary care, I went to the ER, and they said it was this. So then 2 or 3 months later, when their symptoms are worse, they're still saying, the doctor said it was fine. So I'm just going to keep going. And they're not necessarily getting that message of, they saw you once on that day. And if it's 3 or 6 months later and you're still having these symptoms, we need to think about escalate. So we have that range, and that's where I think advocacy is very important. But then going to your other question of surveillance, if you have a family history of pancreas cancer, technically, that doesn't meet criteria for genetic testing. However, genetic testing these days, out-of-pocket testing is about $250 to $300. So if it's something where you think the peace of mind will come, I would say consider getting it done just for peace of mind, especially because a lot of people don't really know their family history. They had aunts, they had a cousin who died of stomach cancer, but we don't really know. When we say stomach, what was it? If they say liver cancer, was it liver cancer? Did it spread from somewhere? We have a lot of mysterious family members with mysterious illnesses. It's hard to really pinpoint family history. Definitely, if you have ovarian cancer, I don't want to speak for gynons, but my understanding is ovarian cancer gets genetic testing or should get genetic testing no matter what. So those patients should know whether or not they have a mutation that also predisposes them to pancreas cancer, like the BRCA genes. We see the BRCA gene, the ATM mutation, PAL-B. There are a couple that we see that we have a pancreatic cancer screening program, roughly speaking, that's using a combination of a lab test that are called tumor markers that look for GI and pancreas cancers, an MRI of their pancreas, and then something called an endoscopic ultrasound, which is a procedure that a GI doctor does to look up close at the pancreas and doing biopsies if needed. The general public should not be getting all that workup because we're going to lead to a few people finding things that shouldn't need anything done, a few people getting pancreatitis from a unnecessary biopsy. So that's not the approach for all patients, but for all patients, it's to be attuned to your body and to your family history and see a medical doctor when you have a problem.
You had asked me my approach. I think it's similar to my colleagues, where it depends on the symptom as well as the severity. So I don't necessarily always throw the kitchen sink at every single patient. But let's say they come in with mild discomfort. I'm like, okay, we're not necessarily looking, the expression in medicine, looking for the zebras. But I tell them we're going to do X, Y, and Z, and that might involve getting an ultrasound, trying some proton pump inhibitor to see if it relieves the discomfort, and possibly seeing a gastroenterologist. But even then, I'm like, you should continue to stay in touch with me, because even if it stays mild, we don't necessarily want to ignore that. And we should do some further type of CT imaging, as you mentioned.
I should mention the other thing is that the new onset diabetes in the older patient, that's another red flag for, again, we don't have any guidelines that say about a new onset diabetes should get a steer, but it's something I think about depending on how new and how radical. Signs of, again, nutritional deficiencies, steatorrhea, which is floating stools or abdominal bloating related to pancreatic enzymes, especially that if there's GI stuff with new onset diabetes, I think we want most clinicians to be thinking of the pancreas. And then because I have my foot in both doors, I don't take care of primary colon cancer for the most part, but I do a lot of surgery for liver metastases from colorectal cancer. So I'm also an advocate for early screening. Just wanted to shout out that now the new age for screening colonoscopy is age 45. But also, again, if you're younger, then if you're seeing blood in the stool or you're anemic, you don't know why, that's something that needs a workup. It's our job. It's just such weird perspective because you mentioned this word zebra, right? And my office is literally, my schedule is zebras. So we're messed up because we're always seeing the rare, unusual. And so it seems like it's like all the time, but we're definitely seeing, I don't want to be alarming. I know it's a podcast. We're definitely seeing younger patients with lung cancer, pancreas cancer, gastric cancer. And when I was in medical school, and I'm sure for you too, it was unheard of to have people in their 30s with some of these types of cancers. Or I have a series of patients in their 20s, not with pancreas, but with colon and gastric. And so that the thing about they're young, and so it can be X, Y, and Z, like that's to me is out the door.
I think it's a function of our environment, our diet, probably other things. But yeah, no, there's definitely an increase. I trained at NYU Bellevue, so I'll do a comparison. So at that time, and I think still now, we had a large Bangladeshi Bengali population that came to the hospital, and as South Asians tend to have a higher risk of heart disease. And so we would be seeing patients who were in their 30s or 40s having heart attacks or unstable angina. And so that kind of got drilled into my head. And so even now, and even if it's not a patient that's South Asian, let's think about heart disease. Let's screen for it. Let's make sure that's not what's going on, even if their discomfort is coming from their acid reflux. So I think, as you were mentioning, the zebras, and for those who don't know what we're referring to, it's basically all the unusual conditions or findings that you don't necessarily think about.
But basically, you're supposed to think about horses and not zebras.
And that is my job as the primary care physician, and I'm comfortable doing that. But yes, every once in a while, and I would say it happens more often than I'd like, but there are times when I have to deal with the zebras and know who to connect with, and obviously how to refer the patient as quickly as possible. So I'm grateful for doctors like you. I'm in New Jersey, so I have a whole network of colleagues where when these issues come up, I know who to refer to.
I tell every now and then, I tell the patients, because they're obviously very humbly grateful for what I'm doing. But I often tell them, like, you need to call your primary care doctor and say thank you, because I know that not everybody will get that workup. And so I often just tell them, the person who saved your life is this person who took you seriously and started this workup that led you to this day. And I said, you pick up your phone and you call your primary care.
I think I don't need the kudos all the time, but I've been blessed. And I hope my patients are listening to this, but I have been blessed with some really good people who are my patients, and the gratitude that I receive at times. I feel so humbled when they do reach out or send me a card thanking me for find whatever I've found and however which way I've helped them. But I could not obviously do it without highly specialized surgeons and other colleagues. As you probably know, I focus a lot on women's health. I've been doing this now for, I can't even remember, but the large majority of my practice is focusing on women's health, and that not just from a GYN perspective, because I'm not a gynecologist. Not to say it's not important, but it's a very comprehensive approach that I take. So in your practice, obviously, you're seeing more of the unusual things than I am. But what do you find women are coming in with more often?
That's a good question. I don't know that I know this. Apart from you saying that I have a real percentage difference, I guess my thoughts on women and certainly what I see, number one, I want to say is the rare, but I've seen it many times, is this issue of, I think women, first of all, they're busy. And they're just whatever level of education, whatever slice of society they come from, they're working hard, whether it's at work or with kids or at work and with kids. And so we tend to ignore our bodies and not take time for looking at what's going on with us. I think that's a big problem. It can lead to delays in presentation. I think anecdotally, I think that I see that more with women. And I always wonder, always hard to quantify, but whether their symptoms are taken seriously, especially in the urgent care setting. I have a series of patients. I almost wrote a case series about it, which is the patient was pregnant with symptoms of an advanced cancer and just go through the pregnancy, everyone around them saying, oh, it's because you're pregnant, or you have rectal bleeding, it's because it's hemorrhoid, you're pregnant. You're vomiting, it's because you're pregnant. It's not getting better, it's because you just have a bad case of being pregnant. I now have a whole series of pregnant patients that have had symptoms. I know that it's not common, so it's easy for me to say, why isn't this escalated? But I just worry that might be the reason, that it's being not taken seriously because we think it's a woman patient who is hormonal or whatever the phrase is, that they're anxious and they're more worried about it than they should be. I think that's an issue. Some of it's whatever you want to call it, bias or our way that we see the lens in as providers evaluating patient. But I think it's two-sided. I think women also tend to overwork. And the prime example.
Oh, yes. Oh, my. I totally hear you. I think I focused on this a lot in other podcasts, as well as in my everyday practice. I think that it is a thing. And unfortunately, I have also experienced the discrepancies that can occur. One of the ways I've leveraged, and you and I come from a very similar background, same background, and we have immigrant parents who have always taught us to be humble, don't brag, don't say you're going to do this, don't tell them that you're important. And so you continue with that mindset. But as I've gotten older, I've realized that I definitely need to use my MD title. I definitely need to, when I go into any kind of special doctor's appointment, I need to basically let them know that I'm a physician to leverage the care. And as I've said to other people, you really shouldn't have to, but it's important because when I have not, some weird things have happened. Not a long time ago, fairly recently. And so it made me realize that this is a thing, but it also humbles me in a way to realize that obviously not everybody has the ability to do that. Not every woman can say, oh, I'm a doctor, I work here, and this is my background. And they don't necessarily have the understanding because they're not medical doctors.
I think that we think of questioning as maybe being challenging. And so we think, oh, I don't want to be perceived as someone who's challenging this authority figure, the doctor. But I find some of the best clinic encounters are the patients that are asking a lot of questions, and they're not doing it with any kind of aggressive tone or that they're upset, but they're just truly going down the list. And I love it because I'm like, this is a fun visit where I'm being forced to figure out how to explain something or why this and why not that. And I love it when people ask me questions that most people don't. And I don't see that as a negative thing at all. So there's nothing about asking questions or expressing your thoughts that from our end is necessarily in and of itself seen as a challenge or I don't know.
So I've advanced in my practice. I realize that it's really important for me to do things outside of medicine. Part of that, even though it's a medical podcast, I focus a lot on a lot of things that are not medical on my podcast. So I like to talk to different people, things that are not in my comfort range, play the piano, do other things that kind of keep me grounded. What do you like to do?
Yeah, that's a great question. So I have a little other side of me that I was lucky that I was again born to a family that gave me lots of opportunities to pursue whatever I wanted. And then I went to schools that supported me as well. I had a prior life as a singer-songwriter. I did a lot of music growing up. My claim to fame is that I sang in chorus with Lin-Manuel Miranda. So he was 2 years ahead of me at Hunter College High School on the Upper East Side. And that was a really great environment that obviously supported music. And then I also, for a long time, did classical Indian dance called Kathak. And as a high school student or a college student, I did both. I sang a cappella at Harvard. And then as I got into medical school and residency, I found dance was just a little harder to coordinate because usually you're with a big group. I went into the singer-songwriters thing. I have 2 albums on iTunes, on Apple Music, for anybody interested. Do a little plug, but that was a really important way for me to release post-call. I have a lot of songs about medicine, about my feelings, about dealing with illness and watching that and worried about, did I do the right thing? These are kind of unique challenges that we have. And I thought that was, for me, it was like necessary to keep going. I took a big hiatus when I had kids, right? Life just stops for a decade. And just recently I've been able to get back into it a little bit more, performed a couple of times, and just can't do everything at the same time, but something's important because I think being connected to that emotional side is very important in ways that we don't understand it. I think a lot of us think that those performing arts hobbies are for kids who are in school. We don't think of it as being something that adults benefit from, but I think they really do, even though I'm not Lin-Manuel Miranda, right? He's a genius and he always has been. But even doing it on a low level, I think has value and allows us to be connected to our patients in some way. And certainly when it comes to dance, I think it's physically an activity. And I think it's also good for your mind to be forced to be thinking about something else. Because you and I, our patients are in our minds 24/7. I'm psychotic. Sometimes the nurses are like, we saw that you put the order in at 4 a.m. And I was like, yeah, I woke up because my daughter had a dream. And then I said, let me just check the chart and see what's going on. And then I saw that the blood pressure was low. So we're always thinking about what's going on with our patients. And that's a problem. And generationally, probably that kind of activity will cease. I'm sorry to say. I think it goes hand in hand. We have to have the feeling of wanting to do it, but we can't actually do it 24/7 in order to sustain ourselves so we can be fresh and emotionally relaxed so that we can be there for the next patient who's going to be anxious, asking a lot of questions. Otherwise, we're going to be a mess. So I think that hobbies are really important. Whatever it is you do, it doesn't have to be a Grammy Award.
Now, there was a time, though, when I used to envision myself as going to the school for the school of fame. I forget what they call it now, School of Visual Arts, School of whatever. And so I would be carrying my violin, but that all changed once I got to medical school. But I am fascinated that I have met so many musicians who are physicians, and I don't think that's a coincidence. I think there's a part of us that it works, like the music, math, music, science. There's definitely a connection there, but I also think it serves as an outlet so that we can release some of the tension and the angst that we go through as physicians.
Yeah, I think Mount Sinai has a program, which I was always honored to be associated with. Everybody's thought, oh, are you a human? I'm like, no, I'm not a human. So that's that humanities and medicine. But many others now, by you too, but encouraging pre-meds to actually not necessarily be pre-med in college, but go and do something else and explore the humanities and know that they can still go to medical school. And there are some of my best friends, and I think that there's a reason for it. And you can't grind the scientific thing for years. Some people can, but it's hard to only do that. And when it comes to clinical care, actually, the emotional aspect of it is a huge part of having and not being burned out. If you get burned out, then you're likely to leave clinical practice, I think.
Maybe we can start up an AI model once that happens. But yeah, no, hopefully not. Hopefully not. I think I have a number of years on you in terms of practicing. So I think, but there's a reason why I asked you, because I have listened to you sing on YouTube. I forget, I think you posted it on LinkedIn. Yes, you posted it on LinkedIn and I listened to it. And you had, to my listeners, she has an amazing voice. So go onto YouTube and listen to her sing. You really do. You have a great voice.
You look pretty hoarse at the end of clinic.
This was a lot of fun.
This was so much fun. Thank you so much.